Hey everyone, welcome back. Today we're going to be talking about how to interpret an arterial blood gas. So what is a blood gas? Right? Now a blood gas can be either venous or arterial. Today we're going to be mainly focusing on arterial. And a blood gas is actually a bedside test that you do for a patient. So it's usually used in the acute settings, so when a patient comes into an emergency unit or a trauma unit. So how do you take a blood gas? Right? You take a blood gas syringe, which is different to a normal syringe in that it's heparinized. It's also small, it only takes about 2 milliliters of blood, so you don't really need that much. So you draw the blood into the blood gas syringe, you close the syringe with the stopper that it's given you, and you go to the blood gas machine, you insert the syringe, and you run the blood gas. It'll then give you either a printout or a readout of the results within about a minute, and you've got your blood gas results. It's very simple. Now for a venous blood gas, you can take it from any site. But for an arterial blood gas, there are 3 main sites where you'll take the blood. You can either take it from the radial artery in the wrist, you can take it from the femoral artery in the groin, or you can take it at the brachial artery in the upper arm. Now the brachial artery is a little bit harder to find because it's deeper, so your preferable sites are radial or femoral. So I've told you, you can take either a venous or an arterial blood gas, but today we're talking more about the arterial blood gas. So what's the difference between the two? Well, a venous blood gas isn't going to give you very much information on the respiratory status of the patient. If you want to check if a patient is getting enough oxygen, a venous blood gas isn't going to give you that information because you are seeing deoxygenated blood after it's already gone through the tissues. If you want a true reflection of the patient's oxygenation status, you then have to take an arterial sample to see what's happening after that blood comes from the lungs before it's been used by the tissues. So you take an arterial sample for respiratory status. If you're only worried about metabolic status, you can take a venous sample. So before we go any further, I'm really excited to announce that the official website for the channel, thehelpamedic.com, is now live. So you can go check that out. You may find some helpful tips. I'll put up some blog posts, some links to the newest videos that we're doing. And also you can find a copy of my new ebook, ECGs for Medical Students, a step-by-step guide, on the website. So you can always get a copy from there. I've gotten some really good reviews on it from the people that have read it, so make sure you check that out. So now you've drawn your blood gas, you've run your blood gas, and you're looking at your results. Now how do you interpret it? The first thing that you're interpreting is pH, like we said, metabolic status. So normal serum pH is between 7.35 and 7.45. Right? Any pH lower than 7.35, we call that an acidosis. Any pH higher than 7.45, we say that's an alkalosis. Now, acidosis and alkalosis each have 2 parts. You can have a respiratory acidosis or a metabolic acidosis. In the same way, you can have a respiratory alkalosis or a metabolic alkalosis. And there are different causes for each, so we'll go through that now. Now, when we talk about acidosis and alkalosis, we're talking usually about 2 ions, right? We're talking about carbon dioxide being your acidic ion on the blood gas, and we're talking about bicarb, which is your alkalotic ion on the blood gas. So if you are in an acidosis, it means either you have too much CO2, which means it's a respiratory acidosis, or you have too little bicarb, so that's a metabolic acidosis. In the same way with an alkalosis, you can either have a respiratory alkalosis where you have too little CO2 and therefore the blood is alkalotic, or you can have a metabolic alkalosis where you've got too much bicarb and therefore your blood has become alkalotic. Now if it were that simple, you could just check which one was low, which one was high, and you'd know immediately. That would be really great, right? But unfortunately, or well, fortunately if you're the patient, your body has compensatory mechanisms. So if your blood CO2 starts going too low, so you're getting alkalotic, your body will compensate by reducing the level of bicarb in your blood, causing you to have a compensated respiratory alkalosis. Now if your pH is lower than 7.35, so you're acidotic, but you've got low CO2 and low bicarb, what that means is the cause of your acidosis is not the CO2, because the CO2 is too low. What it means is that you've got a metabolic acidosis, the low bicarb has caused an acidosis, and now your CO2 has dropped to compensate for that. So you've got a partially compensated metabolic acidosis. In the same way, if you are alkalotic, right, and your bicarb is high, and your CO2 is also high, then that means that you've got a metabolic alkalosis with partial respiratory compensation. So the body has sensed, okay, there's too much bicarb here. Now I can't get rid of the bicarb for some reason, so I'm going to have to keep more CO2 to make sure that I balance out this alkalosis. So what you've got there is a partially compensated metabolic alkalosis. After you've analyzed your pH, right, we come to the thing that's really important in an arterial blood gas, your PaO2, right, the partial pressure of oxygen in the blood. Again, if you do a venous gas, you're not going to get a true reflection of the oxygenation status of the patient. So for PaO2, you need to do an arterial blood. Now you want your PaO2 to be over 10.6 kilopascals. If it's lower than that, your patient is probably not getting as much oxygen as they should. If it's higher than that, that's fine. That can be over 10.6, it just can't be under 10.6. And remember, you're doing this in the acute phase, right? So you can check if your patient was getting enough oxygen when they were admitted, if they were hypoxic then. And also in patients where you're worried about hypoxia, if you put them on oxygen or you're taking measures to correct the hypoxia, you can redo an arterial blood gas after a while and see if their oxygenation status has improved. So you're also checking for improvement. The ABG isn't just for at one time, you can do serial blood gases to see improvement. And you can also check your oxygen saturation on the blood gas. You want your oxygen saturation to be 95% or more. If not, you may need to look at either getting your patient some supplemental oxygen through a face mask or nasal cannulae, or trying to figure out a cause for the hypoxia. After the PaO2, you've got your CO2. We've talked about the carbon dioxide in that it's the acidic ion we measure on the blood gas. And you want your PaCO2 to be somewhere between 4.6 and 5.9 kilopascals. If it's lower than 4.6, you've got hypocapnia. So your levels of CO2 are a little too low. If it's higher than 5.9, you've got hypercapnia. So your levels of CO2 are too high for some reason. Also, if you get a high CO2 and a low O2 on your blood gas, make sure that you actually had an arterial sample, because if you took a venous sample, that could totally throw off your results and you would think the patient is hypoxic when they're actually not. Next we have bicarb, which as we said is our alkalotic ion that we measure on a blood gas. You want your bicarb to be between 22 and 26 millimoles per liter. Lower than 22, your patient is losing bicarb inappropriately for some reason, or they are compensating for an alkalosis, a respiratory alkalosis. If it's higher than 26, then either your patient is in a metabolic alkalosis or they are trying to compensate for some sort of respiratory dysfunction. So higher than 26 or lower than 22, something's not right. Next thing you measure is your blood glucose. Right? Now, blood gases are also very useful in patients that are in diabetic ketoacidosis because you can get very accurate measurements of serum glucose. And you can do serial measurements, like I said earlier, so you can actually get the status of how the patient is improving on treatment. If your blood glucose is less than 4 or it's higher than 11, then you need to check if your patient has some sort of glucose dysfunction. Another thing you can check on the blood gas is your hemoglobin, right? So if you're concerned that your patient is anemic, if they were bleeding, you can do a blood gas and check that HB. If it's more than 10, they're probably not anemic. The last two things you can check are sodium and potassium. Right? Now your sodium needs to be between 135 and 145 millimoles per liter. Too low and they're hyponatremic, too high and they are hypernatremic. Potassium as well, you can check on blood gas. Potassium needs to be between 3.5 and 5 millimoles per liter. If your patient potassium is too low, you may need to correct it, or if it's too high, you may need to correct that as well. Remember, potassium correction mustn't be quick. If you're correcting potassium, you need to do it slowly over a long period so that you don't cause cardiac arrhythmias. The last thing you can check on a blood gas is lactate. You want to know if your patient is metabolizing effectively or if they're in anaerobic respiration. So if your lactate is less than 1, you're probably fine. You may see any lactate between 0 and 1. Usually if it's less than 1, your lactate is okay. And that's how you analyze a blood gas. It's not that complicated. It's just pH, oxygen, carbon dioxide, bicarb, sodium, potassium, glucose, lactate. That's it. It's only a few things, and if you know the reference ranges, then you're fine. So if you like the video, make sure you leave a like. Leave a comment telling me what topics you'd like me to cover next. For more medical student content tips and practical knowledge, make sure you subscribe to the channel. Thanks everyone. See you next time.